very true.
Yeah. Okay, well, I think it's 33 now, so we can already start. So good morning to Florida, and good morning and good afternoon to Berlin. Probably most of the people know me already. My name is Akira-Sebastian from the Institute of Medical Informatics and Department of Anesthesiology. I'm a physician and also researcher, and I have the honor to be monitoring this special keynote today. So I would like to welcome you all to this exciting session with the title, A Novel Care Approach Utilizing Digital Technologies for Post-Operative and Procedural Patients, CareHotel, and the Mayo Clinic. So we all know that we have lots of digital technologies available, not only in healthcare, but especially in other sectors. And we are building platforms, but also virtual care platforms like at the Mayo Clinic. And today's topic is how can we leverage these resources that are already available to enhance the healthcare provision to post-surgical and also procedural patients using another alternative care model, so to call the hotel setting. So let me introduce to you our speakers. Ryan Chadha, he's an assistant professor of anesthesiology and perioperative medicine. He did he's board certified in anesthesiology and did his fellowship in liver transplant anesthesiology and is currently the division chair of multispecialty anesthesiology at the Mayo Clinic in Jacksonville. So he's pretty much overseeing all the anesthesiological care for patients going several different major surgeries. And also Michael Maniaci, he's an associate professor of medicine. He's board certified in internal medicine. And currently he's the medical director of the Mayo Clinic Hospital in Florida. At the same time, he's the enterprise medical director of virtual care program and the enterprise physician lead for the advanced care at home program. And both, I would say, share the passion for innovation and technology in the medical field and also of alternative care models and perioperative care. And I'm really excited to have you here. So we will have 40 minutes of keynote, and at the end, you have about 20 minutes of time to ask questions. So everybody, please, you're welcome to ask questions. You can also write them here in the chat, and then we can go through them at the end of the keynote. After the keynote, I would say, just to inform you, this keynote will be recorded and then uploaded to the BIH server. Thank you so much again to Tim, I don't know if he's here, Tim Ellerman and Patricia Abel. They are from the BIH team who also made this possible. So the stage is yours. Ryan, Michael, very excited to hear what you have to say.
You guys see those slides okay?
Yes, great.
Great. So thank you. We're going to speak of our virtual platforms here, starting with our advanced care at home platform, which really focuses on home hospital because it's kind of the foundation that chases. We went into the CareHotel, but we'll give you kind of the pieces of each of these and the why behind it, and then some of our outcomes, and then plenty of time for discussion, which I find is the most interesting part of these things. We'll try to get through the slides relatively quickly and really try to drive discussions and questions because we learn off each other that way. No financial interests. Mayo Clinic does have ownership, partial ownership of Medically Home, which is a technology company that enables virtual care. None of us get anything out of that. I wish we did, but we don't. So nothing to disclose there. One day I'll be able to disclose something, hopefully one day, but not today. Again, objectives here, you'll see we're going to describe this advanced care at home program and look at the impetus on why we did that. Then Ryan's really going to dive into CareHotel and what our hoteling and post-procedural care looks like, as well as the roles of the anesthesiologists in these alternative care pathways. So before we start with the how, I usually start with the why. I wrote this slide with my friend AJ 3 years ago, and I've never changed it because it's always my first slide. And it's why Mayo Clinic got into home care and hotel care and everything else. It really comes down to the patient and the experience. When people are in the home setting, they have comfort, they have convenience, and they're in control. Unfortunately, the hospital is the place with the expertise, the care delivery models, and the technology. That's evolved over the last 100 years. So there's a scale of balance, and people have to give up one for the other. The big question is why? Why do you have to give up all the comfort, control, and freedom? We try to make hospitals nice, but are they the right answer? And is there a better care model to move the expertise, technology, and care delivery models into an alternate setting, be it a home, be it a hotel, apartment, condo, a shelter, a church, anywhere? What does alternative care outside of walls look like? I ran patient experience for a couple of years. These are several things I heard, along with a long list of others. As much as we try to make the hospital a nice place, people feel isolated. They can't see their family, especially in times of the pandemic. We're known for our great medical care. We're not known for our food, especially when it comes to different race, ethnicity, specialties that they're used to in the home setting. Mobility is poor in the hospital setting. People often don't get out of bed unless they go to the bathroom, maybe sit in a chair. You're lucky if you get to take a walk. People get weak and they have to recover in the rehab facilities or with physical therapy, not from their original illness, but actually from the hospital stay of not moving around. We try to work on communication, but often communication is poor. Both providers and patients don't know what's going on. And then again, sleeping in a hospital or advanced care setting is often difficult. Many monitors, many disturbances on the hospital schedule, not on the patient schedule. This is an article that some of our colleagues in Mayo Clinic, Arizona put out a few years back. And if I said that I had a person and I put them in a uniform and put them in an isolated dark room and deprived them of sleep and deprived them of their favorite foods and did not have their family members visit them and kept them up all night with annoying sounds and stuck them with needles, where would they be? And people would say enhanced interrogation and Guantanamo Bay or something terrible. And I'd say, no, that's a hospital setting. That's what we do to folks. That's their view, their perspective of what happens. And they're absolutely right. If any of you have been a patient in the hospital, you know that it is not a pleasant experience. Besides the experience itself, we looked at other things. 1 out of 5 patients becomes delirious in a hospital, which can also lead to harm and injury. People become weak, as I said before, because they're not mobile. Hospital-acquired infections affect tens of thousands of people a year. Hospital-acquired errors kill hundreds of thousands of people per year. Access to care is difficult, especially under constrained capacities. Most hospitals run 95 to 99% full on a good day. And when they push or have a pandemic, they go overflowing. In the United States, this is less in Europe, but still is a thing where we spend a lot of money on healthcare and people go bankrupt 2 out of 3 times because they get sick. It's not right. If you look at home hospital, people practiced in the home, doctor going house to house bags 100 years ago. Hospitals became institutions of technology and care delivery. Over the last 30 years, the European model of home hospital started up. Spain, Italy, bled into Israel, some of the Middle East. That caught on. Dr. Bruce Leff at Hopkins started this in the United States, late 1990s. And for the last 30 years, if you look at literature, both here and in Europe, great outcomes with hospital at home. Decreased 30-day mortality, decreased readmission, decreased falls, decreased delirium. All the bad things I talked about seem to melt away when people have the freedom and control to get health care in their own environment, with their family, at their own schedule. As we looked on the last 5 years, this hospital at home, which used to be a kind of doctor in the bag, go house to house, has become more modernized. We know what happened with the pandemic and COVID-19 really pushing a virtual care model. But often people ask me, well, if this is so great, if both in the United States and Europe we've seen 30 years of success, why are we doing this everywhere? And it's really because the model hadn't changed until very recently with virtual care. A physician going house to house with a little bag is not as efficient as walking down a ward and seeing 15, 20 patients in a day. You can only get so far in a city. Condensed cities obviously work better where you can see patients, but as you get more rural, more spread out, it's difficult for providers to get the care. Resources are limited. Most hospitals throughout the world have limited resources on physicians, nurses, other advanced providers. medications, and actual equipment. How do you spread that out of your hospital in the community? And finally, if you do, it's only a short area outside your hospital. You can only cover a few miles or kilometers around where you practice, not hundreds or thousands of kilometers away. So what has happened in the last 3 to 5 years that's changed this? And this is really the new virtual model of home hospital, which then bleeds into CareHotel and some of our other virtual modalities we'll talk about. And this is where you take the highest cost resources, the physician and the bedside nurse, and you make them virtual. You connect them with advanced technology, software to drive healthcare, and then you don't try to do everything yourself. You outsource or you build community resources to deliver care in the home setting. So that's really what this model is, and I'll show you how it works here. So first, we have to gather data on our patients. So in the home itself, we have home technology. Virtual tablet that looks like this. That is a connection, both virtual connection with video, as well as an audio connection and audio backup of a phone, a cellular phone. Redundancy is important. That tablet will be connected to the patient at all times. They could reach our nursing staff or physician staff 30 seconds or less. They also know their schedule for the day of what's going to happen in their home, so their communication is kept key. We put devices in the home, not a lot, but enough to collect the crucial vital signs: blood pressure, pulse ox, heart rate, weight. And we connect them with special devices to locate them in their house if they have an emergency, and then feed it with backup cellular connections, backup internet connections, and backup power, so that if one device goes out, 2 more can kick in, and we always have connection to our patient. We get enough technology so that we know what's going on in the home, but we don't make the home feel like a hospital. Most of this is low profile and can fit on a desk, on a nightstand, in a kitchen, on a counter. It works quite well. Next is software. You have to gather this data, bring it back to your medical institution, process it, and then be able to enact orders upon it. I did not want my hospitalists or anesthesiologists or others, or nurses, to have 7 screens of different platforms open. I wanted one platform, our EHR open, just as we treat people in our physical hospital. I want to treat people at home, in a hotel, anywhere else. So you need software in the background driving the orders and the supply chain. The command center is where our providers sit and team. Our command center looks like this. It has physicians, it has bedside nurses, it has pharmacists, case management, advanced practice providers. It's a hospital ward. The only thing missing is the patients. So we can gather there, we can team, we can talk. But again, because this is virtual care, this is just more for convenience and comfort. If there was a power outage, a bad storm, we had to leave town, we could all do the virtual care from our own homes, from a traveling laptop, or from someplace else. So it helps, but it's the idea of virtual command center driving care. And then finally, the care is delivered in the home setting by Supplier Network. All the things that are done in a physical hospital, we've built in the community so that things that you think of, like lab or medications, and things you don't think of, such as medical waste, meals, security, those are all provided to our patients and can execute orders from the physicians or nurses that make the decision to cancel. Those are executed in the home by a supply chain that is not completely owned by Mayo Clinic. In different communities, we own a percentage. It may be some of our own nurse practitioners, some of our own traveling nurses. Other communities, really, we outsource and use the community resources of laboratory, medication delivery, couriers, physical therapy, and elsewhere to deliver the care to our patients. It's our care, it's our medical knowledge, it's their hands and boots on the ground actually executing the care. The most important thing about this slide is not the picture that shows that we build the supply chain around our patients. It's actually the words on the right that say that our goal is to replicate the capabilities of the hospital, but not the actual experience of a hospital. You don't want to just mimic what you do in a hospital at the home and have 19 people come in throughout the day at 4 o'clock in the morning and bother your patients. That's just a more expensive version of something that doesn't work well that I've showed you. What you want to do is have the capability to escalate care if somebody gets crucially ill, but if the patient's sleeping, let them sleep. Get labs at 9 a.m. as opposed to 4 a.m. if you don't need that crucial information that early. Make it a great experience for the patient, be able to escalate care, but don't replicate exactly what's happening in the hospital, only the capabilities when you need to. What that gives us is the command center running the software connected to the patients, supplier network delivering the care, and the patient in the home with the technology. we have to build the care delivery around the patient. I can't deliver care to patients there in Berlin from here in Jacksonville with my medical supplies, medications, and lab. It would take 15 hours for us to send supplies across the pond over all the way to Ugal. So care has to be built around the patient, usually within a 25-mile or 30-kilometer base is what we found a hub works well. But the virtual care can be done anywhere. Just as we're connected now, I could care for your patients in Berlin with Mayo Clinic taking care of them, as long as the supply chains, the pharmacy, the labs, the care delivery around the patient is done there in Germany. That can be done. So on any given day, I can take care of patients throughout the world with my virtual care center. So we're located in Jacksonville, Florida. This is where our virtual command center is. And when I'm on service here, I take care of patients in Florida. But on the same day, I'm taking care of patients in Wisconsin and Minnesota and Phoenix, Arizona. So across the United States, 3 different time zones, 1 physician, 1 set of bedside nurses, taking care of patients throughout the United States at multiple locations with our care teams. And then again, the supply chains that are built there. When we take patients into our virtual programs, we can take them right out of our emergency department before they hit the hospital. People that need hospital care, but do not need to go to a physical building, will move right home. Others need surgery, intensive care, recovery, but instead of saying 5 days in a hospital, 7 days in a hospital, they recover quickly. Once they become clinically stable, we move them home after 24, 48 hours to complete their care at home. We can choose to own these patients just for their hospital care, or because we have the virtual care in the home and they're already there, you can have ownership, longitudinal ownership of that patient with remote patient monitoring for 15 days, 30 days, 60 days, whatever you desire, and whatever the patient's acuity calls for. Some patients that are young and healthy don't need anything. Others that are chronic heart failures, asthma, pneumonia repeatedly, chronic cancer patients, palliative care patients, they may need more frequent touch bases, and you can do that through virtual technology. Here's some of our inclusion and exclusion criteria for our home hospital program. We'll talk about our CareHotel in a second. Really, again, we want patients that are sick enough for the hospital, that are clinically stable, that they don't need escalation for repeated invasive testing, surgery, or ICU level care. Critical care we do still in the physical hospital. Again, it's usually within 25 to 30 kilometers of a care hub. So we just built different supply chains throughout our cities and throughout the country to deliver this care. And again, we do not take pediatrics right at this time. And we don't take advanced mental illness or people that may need certain IV medications at this time as we build out our supply chain. Diagnosis is, again, we started with medical diagnosis. As we got more comfortable in the system, we started to go more advanced diagnosis, including post-surgical care, which we'll talk about in a second. And then something more advanced like post-transplant care, even bone marrow transplants, which took 15 to 30 days in our physical hospital. Now we're transplanting them, bone marrow transplants on day 1, moving them home by day 2, and then doing all post-acute care, labs, infusions, IV medications in the home setting as opposed to in the hospital. We can move people back and forth if we need advanced imaging or more advanced care, but most people stay at home without much escalation or trouble. Finally, when it comes to surgical patients, this is another area we've moved into over time. Anything that's protocolized, if you know what happens on the day of surgery, post-operative day 1, 2, 3, if 10 things happen each day, all you have to do is build your supply chain, your workflows, deliver those 10 things, and you can care for patients. That happens well with advanced inpatient surgery, but the question came up, what about our outpatient surgery, the 23-hour stays, the bread and butter of the majority of procedures that are done at our institution and many other institutions? What about those patients if they don't need 5 or 10 days of care, but just need a day of care? What do we do with those patients? And how do we give them the same experience, especially when many of them travel hundreds, sometimes thousands of miles to get to where we're at? They have no home close by to go to. What do we do with them? And that leads to CareHotel, which now I'll turn over to Ryan.
Thanks so much, Mike, and really just impressive work with ACH that really shows how this set up the CareHotel model. So I'm going to just spend a moment to talk about medical hoteling as a concept. I think, this is something that really isn't described extensively in the literature. as you see, this is a simulation of what a medical hotel would look like. I like the room service touch they have there as well, the free row. But the whole idea of medical hoteling is that essentially it's something where the patient has greater freedom to visit with relatives, to be independent, to function normally. And it's voluntary too. It's something that they have control over, which is, as Mike mentioned earlier, is something that they don't have in the hospital. So it's kind of one of the first descriptions. Another description that you can see, here was that it offers an aesthetic and comfortable environment in which patients can recover restorative care following or even preceding hospital treatment. And it allows patients to be actively, it allows them to be independent, which I think one of the difficult things in the hospital in recovery is your independence. You can't recover, you have to determine how to recover. Now, some patients will recover very well in the hospital. They feel comfortable in the hospital, they like that. But a lot of patients, they don't like that being in the hospital. And the hotels, by their nature, allow you to be more relaxed. They're used for vacations. They're used to kind of be somewhere where you're away from your home, but still being able to be normal. So that's kind of one of the key concepts when you look at medical hoteling. Now, why did we start the CareHotel? The reality is it did start from a capacity standpoint, because as Mike mentioned earlier, we're a pretty small hospital. And as our goals, as you can see in 2022, we wanted to be at 80% capacity, but most days we're usually reaching 90%, if not more. Currently, we're a 303 bed licensed hospital. So with the amount of advanced tertiary care we're providing, we needed some way to offload the clinic, practically speaking. But from a more innovative standpoint, one of the biggest things I want to point out to you is if you look at our surgical patient mix from 2018 to 2022, as you can see here, there's been a significant transition into the outpatient space from inpatient surgeries. So you can see here, we almost dropped 7% from 2018 to 2019, and we moved more patients to the outpatient, or what we call outpatient in bed, which is our 23-hour observations. So how can we basically take care of these patients the same way, but give them the same comfortable experience that they were having without taking up, as mentioned in the previous slide, those valuable hospital beds? So there's basically three key reasons why we kind of moved into took the ACH model, went to the CareHotel. So the first one is, as I mentioned, create an innovative pathway for same-day discharge, surgical, and again, surgical and procedural patients. I want to emphasize that. But at the same time, we wanted to enhance the patient experience, give them the opportunity to recover outside the hospital so they're not tied up in the brick and mortar building. And of course, as we're going to talk about later, there's a lower overall total cost of care to the patient, as Dr. Maniaci will mention later. But more importantly, we can open beds for much more complex patients who require those invasive tests, those ICU level of care, those more advanced monitoring that you can only offer in the hospital setting. So I think a key thing to understand is what can we actually offer in the CareHotel, because this is one of the more important things you have to understand. So we have an on-site nurse there and or paramedic from 11 a.m. to 11 p.m. along with a virtual RN, as Dr. Maniaci mentioned, in the command center. We can do basic Foley drain management, incision inspection. We can do point of care labs and neuro checks and vital monitors, and we can give basic breakthrough oral meds. We can't do any opioids anesthetics. As you can mention, their drains are a big part of surgery, and they can now be pulled at the CareHotel, but they can usually be, we've created several workflows so they can be pulled in the clinic side on post-operative day one. So this is just a couple of visions. It's a hotel room. It's essentially a hotel room. What you see in the hotel room, this is one of our doubles, and you can see there's a recliner that we have for our patients in all the rooms. And what we've done there is take that same iPad technology that Dr. Maniaci pointed out previously, right there, along with vital sign devices and that own dedicated phone, as well as a virtual connection to be able to reach out to the command center nurse overnight, and then during the day they can use the phone to call the nurse that's in-house covering the hotel from that perspective. So there's kind of three things that go into the patient population in the selection process that I kind of want to just kind of go through here from that perspective. So obviously that's pretty simple. We've kind of said it's usually a patient that's a 23-hour stay that would basically be in the hospital just to be observed per se. And they really need to have basically what we call monitoring or light care needs. So they need to have no IV support. They need to be ambulatory. I take this with the exception of the patients that get joint surgery. They're going to be a little bit more limited in their ambulation. They need to be mostly controlled in oral pain controls. And it's really incredible how many patients, and the anesthesiologists on this call will know, with the introduction of enhanced recovery after surgery, most patients are not eating post-op day 0 and are taking oral pain meds. So they almost never need IV pain meds. In addition, with the increase of regional anesthesia, a lot of these patients are not even getting pain medications IV anymore. So that makes one of the biggest differences as well. And then for the most part, we highly recommend a responsible adult. We don't require it, but we highly recommend it because part of being at home is having that support, or being outside the hospital is having that support of someone who can help escalate care, utilize the iPad technology to be able to get the support you need in the situation in the post-operative period. The final implement, there's kind of 3 types of patients that come. There's the patient-driven. There's that patient, as Dr. Maniaci mentioned, comes from thousands of miles away. They just had a surgery. Yes, it's a low-risk surgery, but they don't feel comfortable being without monitoring. So this gives them that opportunity to be outside the hospital, but have some level of care. And as all you anesthesiologists know, the surgeons drive their care. They just don't feel comfortable discharging certain patients. They want them in-house for 24 hours, even though they're not getting any active hospital care. So that's what drives the third one, the second element. And the third one, which I think is the most important, is innovative outpatient pathways. Taking surgeries that would always stay in the hospital and figuring out pathways from pre-op to intra-op to post-op to get them out of the hospital and into the hotel setting for a more rapid recovery. And we're going to touch upon that briefly. So this is a typical patient flow. I'm not going to spend too much time on that, but this is just a typical how they get referred to prior to the case being booked. They meet their discharge criteria and recovery. Once they have their surgery, we hand off the RN, and then we get nursing care during the day from the team, and then the overnight RN will take care of them. And then they check out in the morning like a average hotel, and then they'll attend any post-op appointments as per the surgical protocols are in place. So I think this is a really impressive slide. I actually never, I would say I took this from Dr. Maniaci, because I never actually put all the procedures into one slide before. I've never appreciated, but you can see we have a huge breadth of procedures that are going. And the ones with stars I want to emphasize because they have very innovative pathways to be able to get them through the perioperative process that anesthesiologists were very active in developing for these patients. And a lot of these surgeries you'll be very surprised to, especially I want to point out aneurysm coilings. These are intracerebral aneurysm coilings, our ileostomy takedowns, as well as some of our parotidectomies. We're one of the only centers in the country that doesn't admit parotidectomies for at least one to 2 days after surgery. We move them all essentially to the CareHotel model afterwards. And I'm glad to share, obviously you'll see there's, I'm not going to go through all of these things here, but there's a number of procedures here that we take. And as you can see, again, the percentages are less important. More importantly, is look at the breadth of patient population we've been able to move. And it kind of shows that very few patients actually need to stay in the hospital. We provide very little care for them when they're in the hospital. They can actually go and be observed in this hotel model post-operative. So a couple of the data, a couple of things that we've been able to kind of show in some of our research, and because we started the CareHotel probably in August 2020, and we've collected about 2.5 years worth of data. One thing we did demonstrate is that healthier patients, ASA 1 to 2, are more likely to stay in the hotel versus ones that are ASA 3 or 4. So naturally, a patient who feels that they're clinically stable, we're more likely to want to leave the hospital than the one that is more ill, as determined by their ASA classification. On that same side, one of the big concerns we always have is what were the outcomes, right? You know, you send these patients to a hotel that would typically stay in the hospital setting. Has that affected outcomes? And I want to kind of point out a couple of things here that I think are very important. So some of these things, these top metrics are more just volumes that are less important to the group. But firstly, I want to talk about this ED visits within 24 hours of procedures. We've set the benchmark for less than 5%, and we've been under 5% for our entire time, 5% or less for our entire time of being in the hotel. Now, most of the ER visits have been pretty benign. Usually they're wound issues, urinary retention, common reasons why you would go to the hotel uncontrolled pain. But we've had some serious incidents, like we had a patient post-operative day 0 had a stroke. Patient went for a foot surgery, completely unexpectedly, had sudden left-sided hemiplegia, went to the ER, got immediately acted upon and had a thrombectomy. But our model worked to be able to escalate care using the command center to get them to the care they needed. The other thing too we're going to talk about is you can see the experience we have what we call a top box score for experience, and most patients are immensely satisfied with their experience there, even though they've had surgery within 24 hours. And as you can see here, we've had an explosion of patients going there with a rapid increase now. And we don't even have our most recent data. I think we hit about 150 patients in March of 2023 in a month. So we've been having increased utilization of this model, which makes sense with the breadth of surgeries that we're covering. Now, just to kind of touch upon surgical patient satisfaction, that is something that's the whole point here, as Dr. Maniaci mentioned, is we want the patient to be happy with their recovery. It doesn't help us if we take them and put them somewhere else where they're still miserable, right? And I think that's what's most important. So we looked at our data, as you can see here, in all of these questions, I felt comfortable, I felt safe, I understood how to use the staff responsiveness, my instructions were clear, I felt like I was at rest. Majority of patients either strongly agree or they agree for all of these sections, which shows that we've been able to maintain a high level of patient satisfaction with a high level of safety as well. So I think this is really important. I just want to spend a couple minutes talking about this because anesthesiologists in general, if I can be completely honest, have done a really bad job of expanding, of getting themselves out of the operating room. We do great work in the hospital itself, but we can offer so much when we look at these virtual care models. And this hoteling model is a perfect example of why we can do this. So firstly, the patient and procedural selection and the creation of workflow. So I think one of the biggest things that when this CareHotel model was launched, our surgeons didn't really understand why it was launched. They're like, why would I send my patients there? And anesthesiologists, we work with surgeons and proceduralists every day. So they trust our judgment because we are all about risk-benefit ratios and making sure that the patient safely gets to the perioperative process. So we know which patients make sense to be discharged same day to this monitored process. So no one knows that better than us. And in essence, we work with a surgeon, so we're more likely able to sell this to our surgical colleagues much more easily. In addition, nobody understands workflows better than anesthesiologists. We know how patients move from pre-op to inter-op, post-op, to where they go, whether they go to the floor, and what they need, and what typically they deal with in the recovery room. And we also know those nursing staffs, those leaders in those areas. So we can create those workflows significantly easier than someone like Dr. Maniaci, who is a dynamic internal medicine doctor, but doesn't work in any of those areas. It's more difficult for him to sell this to these groups, and we can do that. And this is where we can lead these things from that perspective. And I want to point out just a couple of the creative workflows we came up with, because I think this was really just revolutionized where the anesthesiologists really were able to push us through. So for ileostomy reversals, we basically created a workflow with our PACU, because our PACU was not going to listen to have to discharge these patients, to hold the patient for 6 to 8 hours. But we worked with them and said, if you can get these patients ambulating, make sure they get their DVT prophylaxis, make sure they eat a meal, and then get them discharged after ileostomy reversal. And we helped determine the selection criteria. We were able to move these patients through. Similarly with cerebral aneurysm coiling, we created a 4-hour observation period in which these patients were observed 4 hours, had neurological checks at Q1 and 4 hours by the anesthesiologist and the surgeon who did the procedure. And then we discharged these patients to the hotel, as well as developing selection criteria. And again, I can't emphasize the surgeon-procedure relationship. The one thing I want to say is, Dr. Maniaci knows this. When we launched the CareHotel, I felt like, I don't know if you have used car salesmen in Germany, but I was selling this to them, and it was, they trusted my knowledge of being able to take care of the patient OR, trust that they would be safe at CareHotel. And that's how I was able to go to all these different service lines and say, listen, I think this particular patient in EP, electrophysiology would be appropriate to go, this particular general surgery patient, this particular urology patient. And then anesthesiology became synonymous with medical hoteling. And that's what is so important when you create these things. And then you become a leader in this virtual care model indirectly, because you understand this better and you understand the surgeon's needs and which surgeons, and I also know which surgeons I'm not going to waste time with, because they're going to be the ones that are going to be too difficult to track from that perspective. And finally, nobody knows how to work in terrible areas like anesthesiologists. We have to work in all sorts of offsite areas, not just surgery, but we work in radiology, in cardiology, in GI endoscopy, in bronchoscopy. We do anesthesia anywhere that is needed. And we understand when we move a surgical patient to an offsite area, what exactly do they need? Anesthesiologists understand that, and it's a perfect opportunity for you to step forward, use your anesthesiologist knowledge to be able to build a model like this. With that, I'm going to turn back over to Mike to give us the last few comments on the deliverables and value of this.
Thanks. Seen some of the outcomes with the CareHotel. This is both combined home hospital and CareHotel outcomes. Admissions actually were over 5,300 now, I think, pretty high. Since we made the slide, we kept going. So thousands of patients worth of experience. The severity of illness of these patients is high. On a 1 to 4 scale, they rate almost 3. These are hospital level patients, both the surgical side and the medical side. They need hospital level care. We're just doing it in an alternative setting. Bed days saved. We've opened up tens of thousands of bed capacity days, which is fantastic for our patients that need chemotherapy. They need advanced surgeries. They need intensive care, help with COVID. We did not have to shut down elective surgeries like many other places did during the coronavirus pandemic because we had these alternative settings to put patients into. They still got their crucial medical care. They didn't want to put stuff off for a year either. So it's not only just opening a bed, it's really making them, getting them, somebody says, oh, a knee surgery is not that important. Yeah, it is to the guy who can't walk. So even though it's elective, it wasn't elective to them. Experience always rides high. We've done internal studies looking at safety, readmissions, mortality, equivalent, if not better, than the physical hospital setting. People often ask about costs. How much do these programs cost in the long run? I come back and say, if you ever look at a hospital bill and what's actually billed, only half the cost goes towards patient care. The rest goes to overhead and capital costs, which is the buildings themselves, these hundreds of $1 million buildings we build, the power, the water, the sanitation, the waste disposal, the depreciation of equipment, all that is huge. When you look at these alternative care settings, the in-home or in-hotel care, the medications, the labs, that costs much less than the overall cost of the hospital. You do have costs for running a command center and running a supply chain, but when you compare the two, this costs less at scale over time. There is a potential for savings, could be break even, could be 5%, it could be as high as 15% that I've seen from different studies. There is value there in not doing everything centralized and just putting money more into delivering healthcare than actually building healthcare. And then beyond the actual apple for apple costs of things, there's the value equation of this. When you're owning patients longitudinally and putting them in a better environment, that's better care. They recover better. They come back to the hospital less, so readmissions go down. They use the emergency department less moving forward, or you can escalate care in the home or hotel as opposed to going all the way back to the emergency room. That both frees up your emergency room and makes patients engage sooner. They do report symptoms faster when they have virtual technology. When they have to call in or come to the emergency room, they'll wait 3-5 days until they're at death's door before they say, okay, fine, take me in. Usually a spouse bringing them in or somebody else saving them. Our patients are very stoic or stubborn at times. Whereas if you can just push a button on a phone and talk to somebody, they do that. Hey, you don't look so good. Let me send somebody to the house and fix this. So you catch a disease sooner, you make them better faster. They recover faster because they're mobile. And then finally, you're opening bed for a critical patient. You want to talk about CareHotel itself and some of the outcomes?
Sure, yeah.
I'll click forward.
Yeah. So basically, as you can see, we talked about one of the biggest goals there was to lower the total cost of care, but more importantly, save that bed that we could have for a more critically ill patient, like Dr. Maniaci mentioned. And the reality is these procedures, whenever we admit these 23, at least in the US medical health system, a lot of these procedures that we admit for 23-hour admissions, we don't get reimbursement for because they're not expected to be in the hospital quite often based on our insurance billers from that perspective. Now, what we've done is for the patient, for the hotel night, we don't charge the patient. We basically have these rooms booked for eternity in the hotel, regardless of whether or not they're filled with patients, but we do not charge the patient for that end. We cover the cost of the staff, but the overall impact net revenue, as you can see, is only $25 per case. But the one thing you can't appreciate is that, again, we didn't use that bed in a patient that we were not going to reimburse for. So now we took it with a larger surgical patient, a cancer patient, a complex medical patient. That bed is now being utilized by that patient, which will have a significant potential reimbursement down the road. But obviously, as you mentioned, each health system will be different. So you want to summarize?
Go ahead.
So I'll just end, but basically, as you can see here, that these models are going to become the new pillar of medicine. I think we have to start. I think, as you can see, I think we were obviously driven by innovation, but also by necessity. I think the reality is it's going to happen everywhere. The hotel itself really provides an effective environment for post-procedural patients who require observation. Medical hoteling in general is something that all institutions should consider, especially if they do large volumes of surgeries. And I just want to emphasize again, anesthesiologists are not limited to the OR setting. You can play a critical role anytime a surgical or procedural patient is involved, especially in the virtual care app platforms. Anesthesiologists can play a critical role from that perspective. And with that, I think we'll take questions. So thank you again for having us, and we're looking forward to the discussion.
Thank you so much.
Thank you.
Any questions?
A lot of information we know, but go ahead.
Yeah, a lot of questions, a lot of information. So it's amazing.
I think also, Akira, you have our contact information. So if someone needs to reach out to us just before we run out of time, please feel free to share it with whomever. We're glad to talk.
Fantastic.
Same thing after the fact. If somebody has a question after they watch the recording, feel free to email us, and we're happy to discuss.
Great. Yeah, thank you so much. Yeah, I was pretty surprised. You said aneurysma coiling and reversal of ileostomy, and yeah, that's pretty serious surgeries. Putting them into a hotel. I don't know. I talked to my head of anesthesiology 2 weeks ago or something, and we talked about hip replacement, which was also on your list, and which can also be a big surgery. And yeah, the question is, how did you convince the surgeons to get these pretty high risk surgeries out of the hospital then in the end?
Well, I think there's kind of two things you have to think about. First of all, the reality is I'll be completely honest, is billing. That's one thing that comes to these things. A lot of these surgeries are looked at as outpatient surgeries in the United States. So total joints have become that group. They're looked at, they should be discharged same day. I think the first thing you always need is you need a partnership. And so the thing is, I alone will not be able to push a group to do this. So you need a partnership. And I think we're very lucky. We have one orthopedic surgeon who was very passionate. And this has only been one that I would say, probably in the last year, it wasn't one of the first ones we did, but I would say in the last year, it's become a lot more prominent in same-day discharges in general, and then to go to the hotel. So you need a partnership. And I think the partnership between anesthesia and surgery makes a difference, as well as their administrators. The other thing too, the key thing I would say, just not with hip replacement, but anything, is you have to take responsibility as anesthesiologists. You have to own this model. And I would say in the first few months, I'd say the first year and a half of the CareHotel, I was very actively involved with knowing what was going on. I was huddling once a week with our nurse administrator, to be like, what's going on? What were the issues with the patients? What do we need to fix? The reality is most surgeries go well, right? Most patients do fine. That is just the reality. We're very lucky. Our surgeons are very talented. Our anesthesiologists are very talented. Things follow a typical protocol, right? 95, 96, 97. But for that 1% or less where we have the issue, we immediately intervened upon it. That was the thing. So whenever there was an issue, when our surgeon reached out to me, I would huddle with my team, and by the end of the day, we've solved this problem, or we have talked to the patient, and we made sure they understood why that happened, or this is what we're going to do in the future. And I think that one was very key in the early modeling. And that's why you can see we only started with probably 3 or 4 surgical groups when we started. And I didn't really talk about that. When we started, our biggest group was actually spine. Spine was actually single level spines were actually our biggest group. And then we moved into urology. But when we had success with those groups, people were more likely to do it because they're like, well, that's service lines doing it. Well, I should be able to do it. I should be able to do it. And that's why we were able to have the breadth of pretty much everywhere we work to be able to touch that from that perspective. So I think that was really the biggest thing. You had to show proof of concept, and you really have to be early on. You have to be immensely engaged. I would say now I've been able to back off significantly because it's become a pretty routine, and they reach out to me when they need it. But now they put hundreds of patients through the model, and they feel very comfortable with it, right? It's just those early, whenever you get a new surgical group, you have to be. So I didn't talk about renal biopsies, but that was one of our new ones. it came to our attention about 6 months ago that we were keeping all renal biopsies for 24 to 48 hours in the hospital just because they might bleed.
Mm.
And we were like, well, that's not a good reason to keep them, right? So we just launched a new workflow for the first 6 or 8. I was very actively involved tracking the patients. Now the radiologist knows, they feel comfortable, the nephrologist knows it, and now I've been able to back off and go from there. So that's kind of the way I kind of approach it, not just with hips, but basically all. So partnership with your surgical and proceduralists, and then aggressive early follow-up in the first 6 months or first 20 to 50 patients. You have to be very involved with reviewing and making sure their outcomes are good.
Absolutely right.
Okay.
Change is difficult in this virtual world, but as long as you build a system that is functional and functions well, and you start with little bites, just a champion group and just a couple procedures, then you can expand. I mean, like you said, we started with a few procedures. Now we have the big long list. Same thing with home hospital patients. We started very stable arm cellulitis and basic pneumonia. Now we're doing bone marrow transplant and post-kidney transplant. So, and I think people felt more secure with the system, not only seeing the success, but also when something went wrong. When they saw a patient get sick and we escalated very quickly, we were able to control the environment and the patient was treated just as well as they were in a physical hospital. They said, oh, you got this. Even if everything goes wrong with this patient, they will still get excellent care no matter what, even if they have to be brought back to the physical hospital, even if they need surgery. They saw that side of it too for 5% of patients that didn't need an escalation. They saw the success of when things don't go well. And they go, oh, well, if they do well, great. If they don't do well, you're going to own them anyway. So therefore, I feel very secure with the system.
Mm.
That's what you need.
And I think that's kind of where, again, to kind of not emphasize this point, but I know as I hear you're an anesthesiologist, that's what we're there for, right? We're there when stuff goes wrong. The thing is, we should not be focusing on that. And that's the way I've always approached the hotel. It's like, okay, every time we took a new patient population, I'm like, can we handle it if these complications happen? Can we handle it? And there's been some that I've said no. I'm like, this one, or we've had to take it slow. We've had to kind of be a little more selective early on because we were still not in the infancy phase of still learning. And that's where you plan for the worst. You could always, when things go fine, you don't do anything. I mean, things go fine. It's really being able to deal with those complications successfully and making sure the patients don't get untoward harm. These complications will happen. This is the best effort.
So were there any code blues at the hotel where you had to react very quickly?
Well, knock on wood, no. But we've had MI, we've had stroke, like I mentioned,
Okay.
and we've had bleeding.
Mhm.
But luckily we've had, and again, the reality is we're picking low. These are for the most part semi-elective surgeries, right? So these patients are usually pretty well optimized from a cardiopulmonary standpoint. So if something did happen, it would probably, it's not to sound crude, but it would probably be just a random event. It would have been something that would have been not able to be productive realistically. But the hotel I didn't mention is right on campus.
That's right here. The surgeons can look out the window of the hospital and see the hotel. So that made them feel better.
That's good.
It's right there. And that's when the occasional, this very few 2 or 3 patients did have serious events. Ambulance was there picking up, moving back to our emergency room in seconds. We had them within minutes in our ER. It was better than them being discharged and going home. I mean, it was.
The thing we didn't mention also is that when they had this issue, the command center nurse was already aware of the patient. They called the ER. The ER was expressed as a patient coming in, you have no clue. They're like, this patient has history XYZ. They had this surgery. They called the primary team. So the surgical team was already aware. So the care coordination was like it was in the hospital. It was just not in the hospital.
So I think we talked about continuous monitoring before. Is this something that you will be implementing, or is it already implemented? Also regarding real time, maybe other metrics that you want to measure, like real time early warning scores, not just the vital signs, but also other accumulated parameters that could maybe represent deterioration more accurately.
Okay. Yeah, so continuous monitoring we don't do as far as continuous telemetry in the home hospital or care hotel setting right now. Again, that's not because we can't do it. There are devices that can continually monitor different bio patches you can wear. The question always was, what would I do with the information? If somebody is 30 kilometers away from me and they have a continuous rhythm that keeps changing, that they need IV diltiazem or something, am I really going to do that in the home setting, or is that better suited in my cardiology unit here? and take a heart failure that needs once a day furosemide to home setting. So that's why we don't push that right now, is what would I do with the data and how much in-home care do you need? With the hotel, because they're close by, we could do that if we needed to. Luckily, most of these procedures, we've not really pushed a lot of the continuous telemetry. We found people are so active in these settings, you get a lot of noise. You have to have the right device on a patient because 95% of what you're picking up on their continuous telemetry is them going to the bathroom or moving around or playing tennis or something because they're just so active with it. They feel so well. So you don't want to take up your staff's time responding to false events. So then we start to look at AI and machine learning to start to look at some of these patterns of data we pick up and what is a true event and something we should worry about and what is not. I think as our AI and machine learning gets better, we can use a lot of these, one patches that collect all data information for our patients in all these alternative settings. And then we'll be able to rank them with deterioration scores. This patient, based on his labs, on his patch, and on his past chronic history, has this likelihood to deteriorate from X, Y, or Z in the home setting. So therefore, watch him more intensely versus somebody else who's healthy, watch them less intensely. So we'll go by acuity, not just by volume or by different types of things.
I think the problem is too, I think the thing is, this is where the mindset has to change with monitoring. And we were talking about this before the call stopped. I think, remember, if we're going to monitor them, the thing is that defeats a lot of the comforts of being in a hotel, having stuff stuck to your chest, having these things being beeping, having things coming from that end. And I think, because I knew initially when we saw some of these new, monitors where they go like this single stickies and stuff, I initially thought that would be great. Naturally, but the reality is these events that happen, these monitors rarely pick up the events that are going to cause, right? They're rarely going to be able to pick up something that's going to really be actionable, and more likely they're going to cause more trouble. And you also then need another resource who's going to watch the monitor. You need someone who's actually going to be staring at that also from a cost standpoint, right? So I really feel that's my one thing. I think it's all about patient selection, and you really want to kind of keep that patient comfortable, monitor if necessary, but if they truly need monitoring, they should be in the hospital if you're that concerned from that perspective.
We did a study of people on continuous monitoring here in our hospital, and one day we had over 100,000 alarms go off with less than 100 actionable items. Off those 100, almost 200,000 alarms. I mean, it's amazing what we do with what our monitoring, just because it makes us feel safer as providers, maybe even makes the patient feel safer, but it actually doesn't advance medical care any degree. I see Eduardo.
Eduardo.
Hi, thank you for the excellent presentation. I'm Eduardo, I'm also an anesthesiologist. I'm actually a colleague of Akira at the hospital. And I wanted to ask you if there is any legal difference for the patients staying at the hotel in comparison to the hospital normal patients. Because if something goes wrong, maybe it's a different level. So I wanted to ask you what's your experience there.
So luckily no experience. Yeah, luckily no experience. So Akira, so now we know we're going to get a code and a lawsuit because you both mentioned them right now. But in all honesty, I think so. The key thing to understand from this, and again, I didn't talk about this, is that these patients are discharged from the hospital, even though they're in the monitored setting. So it's basically like a service that Mayo Clinic has provided, but we do not discharge them unless they meet discharge criteria from the PACU or if they're going to one of our observation units for a little bit. So they need to still meet discharge criteria. So I would say legally there would be, if anything, we're supporting them more than they would ever be supported, because normally they would go home, right? So if anything, we're giving them more support than they would ever get. We would never discharge a patient. The one rule is that, and the nurses know, the hotel meets is irrelevant. I can take a marginal patient and send them out now. No. They still need to meet their PACU discharge criteria, the surgical discharge criteria after surgery. So for orthopedics, they need to pass PT. They need to be able to void. They can't be orthostatic, et cetera, et cetera. For gyne, whatever their different steps are, we are pretty good about that. And then any concerns, and then if a surgeon has an issue intraoperatively or procedural, they're going to keep the patient, right? They're going to say, I don't want to keep the patient. So that's my thought. They're discharged based on discharge criteria. So there's no reason why, if something happened in the hotel, granted, if we didn't act upon it, that would be something to be questioned. But we would act. The beautiful thing is we can act upon it because they have an iPad there. They hit a button and say, I'm having XYZ problem. And our team would go into action, whatever was needed.
Yeah, so that's the status for the CareHotel. And the home hospital program, they are still under our care under inpatient. Both of these programs are completely voluntary, and there's a long consent process at the beginning where we disclose, hey, you're going to be at home in hospital care, you're going to be in CareHotel as an outpatient or a discharge patient getting procedural care. Here are the risks. Here's the benefits. I would say about 3/4 of the patients who are offered this say yes to both programs. 1/4 don't feel comfortable. That's perfectly fine. Again, we do not force anybody into the system. It is completely voluntary, and we disclose every single thing that could go wrong, which is usually technology connections, but some of the medical issues. And again, knock on wood, we built a very good safe system where the amount of escalations is minimal. No patient deaths in CareHotel. Out of the thousands of patients we've done at home hospital, only 2 patients that were both do not resuscitate that ended up passing away from natural causes. So we've done well over time, but it comes back to building the proper protocols and then engaging the patients, engaging the surgeons and all the other providers, and everybody on the same page. Once they have that mindset and they've accepted it, things usually go quite well. And our lawyers were there every step of the way to make sure that all the processes were followed properly to protect both the institution and the patients too. So you want to protect both sides. I think our legal team has done a good job of that.
Okay, great.
Thank you.
Maybe we have time for one last question. Anybody? No, I would have one. So regarding the patient engagement, how do the patients accept the technology that you're offering with the iPad, but also measuring the vital signs themselves, probably? And is there something like a patient portal where they can also look into, or is this iPad app also having a patient portal where they can look at their data that is collected?
Sure. Engagement's been good. We made it very simple. The tablet has one big button to connect to the team, which was the most important thing, not multiple screens. One thing you touch, you're connected. The scheduling's on that. And then we've just selected a couple things. They could see their vitals or some information we push them. We made it very simple, straightforward. I think with the pandemic and people, I'd say if this was 5 years ago, they'd have a little more trouble. Now it seems like everybody can engage in some sort of Zoom or Microsoft Teams or FaceTime call. We made it that it was crucial that it was just that engaging and easy to use. When it comes to the biometric equipment, we tried to use the most patient-friendly, highest rated from a patient experience standpoint. We gave it to different patients, both and also younger patients, people that we weren't going to treat, but kids, people with mobility problems and mental problems as well, behavioral problems, just see how everybody engaged with the equipment and could they use it. We do extensive education with them to make sure both them and their family members know how to use the equipment. And then again, if there's ever a question, they can dial us up on the virtual tablet and we can walk them through use of any of the equipment if there's a question. It went a lot smoother than I thought. I had more problems getting the providers on board of accepting this form of care than the patients loved it, especially at the time of the coronavirus pandemic. They did not want to be in the hospital. They did not want to stay after surgery. They wanted to get away from us and closer to family, so they engaged very quickly. Okay,
great. Yeah, I think we are at the end of the session. Thank you so much, Ryan and Michael. It was a pleasure and an honor to having you here, and hopefully we meet once, maybe in Berlin, but also maybe in Florida. It would be great.
We will do both. Sounds wonderful.
And feel free to reach out anytime. I'd love to talk about the experience of it. It's the ACH hotel. It's been a great experience. We love to share the knowledge. I think it will only benefit everyone. So we want to be able to help anyone who's interested in these things.
Great. Yeah, same here. Reach out to us anytime. Christoph, also from the Mayo Clinic, who's moving to Boston, was already visiting us. He studied here, and I think he also got the connection to do both, which is great. I thank you. I'm really appreciate that he's very open and connecting us with all the people he knows. Yeah. All right. Yeah. Thank you so much. And thank you to all for participating, and have a great day.
Have a wonderful day.
Yeah.
Take care.
Take care. Bye-bye.